All right, and away we go. So first I want to introduce myself, Chris Langmeyer. I don't know a lot of you in this room. I've been in healthcare technology for about 20 years. I've held pretty much every position from BNet 1 all the way through regional director. About a year ago, I joined PartsSource, and I work with large independent service organizations to help with exactly what we're going to be talking about today. In the back of the room, I have Nicole Koharic. You want to go ahead and introduce yourself real quick? Thank you. We also have Chelsea Spangler in the back. She's an enterprise account manager that many of you work with, so she's in attendance as well. So I wanted to start off by saying that this is not a PartsSource sales pitch. This is information that you can use regardless of your vendor, regardless of whether you're in-house program or an outsourced program. We wanted to focus on ways that you could use this regardless of what service model you have. Take these back to yourself, to your shops, and implement some solutions that can make an immediate direct impact on your cost and availability of your parts as well as service contracts. All right, so really, data is driving the future of healthcare. Data is being used all over the place. It's being used for disease detection, treatment, equipment maintenance. It's everywhere. And in today's economy, you know, expenses are rising a lot faster. And we're having less money to invest in services, technologies, or the labor required to provide world-class service. Doing more with less is the new norm. I mean, I think everybody in this room feels that you're constantly being pressed to do more, lower your costs, increase your availability. And so what we're going to talk about in this session is a way that you can, some of the drivers to shift to a data-driven decision-making. And so we'll jump right into that. Looking at the top left, you can see that 66% of hospitals expect supply costs to grow over the next year. So 66% say, yeah, supply costs are going up. 20% spike in labor costs due to labor shortages. They expect margins, operating margins, to decrease by up to 15% by 2027. And in 2024, leading into 2025, they expect capital spending to be flat. Half of the survey expect capital spending to be flat. So what that means is that you're going to have to keep that equipment running longer. So why is it so important to use data to drive decisions? So looking at what you did before only gets you so far. As we walk through this, looking at data-driven decision-making helps make decisions based on facts, not feelings. I think a lot of historical decisions have made based on relationships. I know this vendor, this guy shows up, gives me donuts, things along those lines. I like this person. That's a common thing that we deal with in today's market. Now, if you're in a leadership position, it's important to use data for those decisions to remain unbiased. I mean, you see that all the time where people make decisions based on feelings, and that can cause other issues throughout your organization. So the most informed decisions come from data that measures your goals and is available in real time. I think that's a big key is, again, looking at what you've done before only gets you so far. You need access to real-time data to make those decisions on the fly. But not every decision is going to have data, but the most actionable and impactful ones are going to have that data. I would be remiss if I did not talk about data accuracy first, because bad data will ruin things. It can have a detrimental impact on the outcome of your decisions. There's a lot of risks associated, flawed strategies, missed opportunities. And bad data can come from a lot of different sources. It can come from data entry errors. It can come from outdated information, poor data integration process, CMMS accuracy. So what you can do is you can start with data governance policy. Put a set of policies and procedures in place that ensure that your data is going to be secure, it's going to be quality, and it's going to be available. I worked for a small health system in Central Ohio for a while, and when I showed up, there was no data governance for their CMMS. It was the Wild West. There was no access control. Everybody could do anything within the database. So every time a new piece of equipment came into the hospital, it was just whatever they typed in. So if somebody spelled infusion differently, there was infusion pumped in there 4, 5, 6 times. It took about 6 months to clean up that data. But after we cleaned up that data, we recognized extreme savings in our parts and our procurement practices because we were able to look at from a modality level across our entire inventory and make decisions based on that, instead of the way it was previously, where you had 5 or 6 different models and you couldn't really look at that from a costing perspective. So I cannot stress enough that before trying to implement anything, look at your data, make sure it's secure, and then access control is key. If everybody has access, you will wind up with problems. All right, so we conducted a survey of HTM leaders across the country. I think there may be somebody in this room that participated in that survey, maybe in the back there, Ken? Possibly Ken did. So, but what this is these are the goals for 2024 in ranked order. So you can see bringing specific repairs in-house is a key driver for HTM leaders. And I want to say that this was HTM in-house HTM program leaders that we surveyed for this. Standardizing processes and efficiency to create efficiencies. Demonstrating the value of their in-house team. Is anybody here part of an in-house team? Perfect, a lot of you. So what are you doing right now to help show the value of your team? Anybody? Perfect. Yeah. And so you're being asked to do more. You're trying to find ways to better integrate yourself with the clinical staff and provide value that wouldn't typically come from a biomed department so that you can maintain that. Now, reducing operating costs is another goal, obviously. I mean, we're all looking to reduce costs wherever, regardless of what you're doing. Implementing or upgrading your CMMS. So a key part of data is having a CMMS that has the data capabilities that you need to do these type of things. So is anybody undergoing any type of CMMS transition or ERP transition? Okay, yeah. So, and I'm very familiar with AIMS, and they have a lot of great data modules where you can pull this information out. So as long as you set the foundation when doing that transition properly, then you will have access to that data to be able to make these type of decisions. Taking ownership of capital replacement planning. I think it's very important, and it's often a miss in health systems where biomed is not an integral part of the capital planning process. Is there anybody here that's not part of the biomed department is not part of the capital planning process? Working on it? Yeah, I think it's really important because when you're involved in that, you can look at total cost of ownership, because a lot of these purchases happen where they look at the bottom line. This one costs, you know, 100,000 for this. This one's 150. We're going to go with 100. What they don't look at is how much does the PM get on that? What's training going to cost on that? You know, how much labor is it going to take to maintain these assets over the life cycle? And especially if we're going back to maintaining things for longer, that's going to stretch out further and further. So looking at payback time on training, looking at all those aspects, having biomed at the front end for those negotiations is extremely important. Integrating with other health systems. I know this is happening all over the place. I know there's some folks in UK over here that have acquired a couple of health systems out in Eastern Kentucky as well. And I think that's something that a lot of health systems are looking to do, is if they can partner or combine, then they have better purchasing power and they can drive down some of those costs. And then finally, taking ownership of service contracts. I've seen a lot of different models across the country, really, of how service contracts are owned. Some departments own their service contracts and they make the sole decision. And what we find is that decision doesn't always match throughout the organization. So you could have 4, 5, 6 models and you're paying widely different prices for sometimes the same or very, very similar services. So taking a much more standardized approach to service contracts and evaluating those, and we're going to get into that, that's the second opportunity we're going to look at today, is really key. And it kind of brings us back to step one, is if you're looking to bring repairs in-house, you have to know what service contracts are out there across the organization and be able to evaluate that and look at those low dollar, those low hanging fruits that maybe somebody put in place 2, 3 years ago, and they're hitting the easy button every year when that contract comes up. I don't want to worry about that, just read it. So being involved in that point and then being able to bring those repairs in-house is going to help increase the value of your department. It's going to help drive costs down, and everybody wins in that scenario. All right, so some key findings that I wanted to go over real quick before we jump into a couple of opportunities. Multiple market forces are buffeting HTM leaders all at once. I think anybody that's a leader in this room, and even some of the technicians in this room, see that. You're getting hit from every direction. Clinicians, you're getting hit from all your legal departments. You're getting hit from your finance departments. Everybody is coming at you with this stuff. So we're seeing an aging HTM workforce. I think a lot of people are seeing that. A lot of people are retiring, and the growth in education is not matching what we need to fill those jobs. We're seeing a shortage of HTM leaders again. We have a volatile economic climate, and health organizations, higher operating costs and constrained reimbursement rates. I think that we all feel that. Fragile economic climate. I don't want to get too far into inflation. We saw a big spike during COVID. It started to come back down, but we're not seeing those prices come down to pre-COVID prices. We're not seeing that happening. So we're still seeing a slight increase. And then looking at more frequent and uncontrollable supply chain disruptions. What happened with the hurricane down in Florida that knocked out the saline solution plant? What happened with the boat, the ship, the large ship that hit the bridge in Baltimore that shut down the port for months? I mean, all of these things, we have no control over this type of stuff. And it definitely impacts our supply chain. So what can we do to help with any of these factors? We're going to talk about a few of them, but redundancy and criticality, and looking at that availability and measuring all those aspects and then making decisions ahead of time is the way to go. Looking at that data and using it to your advantage. The next one is, there's enormous pressure on you to hold down costs. We talked about this a little bit already, is they're delaying asset retirement. You're going to have to maintain it for longer. You're seeking savings by changing historic purchasing behaviors, looking for high quality, lower cost parts. We're going to talk a lot about that in just a few slides. Scrutinizing the relative costs and benefits for different service strategies. Hey, can you cancel that contract and go risk? Can we save some money here? Is there anything we can do? Adopting new and more granular budgeting and forecasting approaches. So instead of that kind of old peanut butter spread method where we say, hey, you have $100,000 to spend on biomed this year, that's it. Looking at it from a model and modality aspect and say, okay, well, do we need a service contract over here on this thing that's at a clinic that's only open Monday through Friday and they have 2 of it? Maybe not. But what about this one that's in the ER that's constantly being used? And if it goes down, we have a bottleneck and we can't serve the patients. So looking at it more granularly and budgeting and planning accordingly is definitely going to be the way to go. And then just adopting a formal medical equipment and healthcare technology service strategy. So a top-down strategy says this is how we're going to approach service, and then looking at those in a more granular fashion. And the last key finding is that data, again, the whole point of this discussion, data is essential for healthcare organizations to respond effectively to this new reality. The past state of HTM is characterized by clinical preference, institutional knowledge. Like I mentioned before, the doctor says, I want this thing because I'm used to it. Is that the best thing? Sometimes the hospital says, well, the doctor's the best thing, so we're going to buy that. That's a decision we have to live with. But if you can have a conversation about that thing or whatever it may be, for instance, I was at another hospital in Minneapolis where they were looking to buy a new anesthesia machine. And it was again the bottom line. They were looking at the bottom line, and I looked at all the maintenance costs associated, and it would have actually cost them an extra $20,000 a year just for that subset of equipment to maintain them, overpaying, I believe, it was an extra $30,000 or $40,000 over, I want to say, 10 assets up front, and then their year-over-year cost was much lower. So looking at that holistically. All right. So here's what we want to talk about. And I did want to take a pause real quick and say that you are the first group that's seeing this data. This is based off the report, as Nicole said. And so the full report will be coming out in probably the next few weeks. And if you're interested in that, we do have the roster, so we will make that report available to you. It goes into more detail on all of these opportunities. What I'm going to focus on today is opportunity 2, optimizing cost and quality in parts, and opportunity 5, which is service contracts, essentially optimizing your service contracts and looking at those from a holistic format. Okay. So optimizing cost and quality in parts. One of the pieces around this is really looking at your quality return rates. So I'm not going to read everything on the screen. Go ahead and snap some pictures if you like, but looking at quality return rates. And I think defining those return rates is very important. Defining what is a quality return for you. Is obviously we'd say a DOA is a quality return. But if you don't specify the types of returns and track those within your system, that can be also detrimental. Because if you're just looking at all returns, like if I bought 2 things and I returned one because I didn't like it or it didn't fit, that's a 50% return rate. That's horrible, right? Well, not really. I just didn't like it. I mean, that's my fault. So that's not the vendor's fault. So looking at those from a holistic standpoint and really targeting what is quality and making that definition up front, again, going back to building that strong base, making sure your definitions are correct, having that data accuracy and quality. So time is of the essence when equipment goes down. I know everybody's gotten a phone call, 6 o'clock on a Friday, CT and ER is down, we need the OEM here yesterday. Those things happen. At the moment, most hospitals just get the OEM here, get them here now, and get it going. Is that the right decision at that time? Is there anything that you can do as leaders to make that decision less pressure, less stressful, less impactful? You know, can you look at, is there an option for redundancy? Can you have extra parts, you know, forward stock parts on hand to correct that? Do you have other equipment that you can use that's the same, that'll provide the same accuracy to your clinician? There's a lot of factors that you can look at to mitigate these situations coming down the pipe. So again, the past state is based on decisions characterized by clinician preference, institutional knowledge, and influence from OEMs. Not that it's bad, you know, there is some situations where people are pushing with things, and that's not just OEMs. You have OEMs, you have aftermarket, everybody wants a piece of that business. So, but you can make decisions based, and more cost-effective decisions based on the data without losing that sense of urgency. Like I mentioned, key data elements that providers need to mention, to make the right decision are the quality return rates of OEM. So again, defining what quality is, and then tracking the quality return rate. You can track overall return rates as well. That's an important picture, but the quality is the piece we're really focusing on. Then you want to have the quality return rates of compatible replacement parts. So if you're buying those aftermarket parts, what is your return rate from a quality perspective on those? And then the last piece is the potential savings from buying compatible versus OEM parts. Quite often, and we'll show this in a couple of slides, the pricing is much more beneficial on aftermarket parts. But if you don't know the quality rates of your OEM part and your aftermarket part, making a decision purely off pricing could not be the right decision. Maybe it is. It's up to your organization. All right. So we track all three of these data elements for both OEM and third-party vendors, and then we organize them by 20 different medical equipment categories. These charts are showing biomed and imaging rates. Now, as you can see, if you're looking just OEM versus replacement, there is a 0.3% difference in the return rate, the quality return rate, 0.3. So one extra return out of every 200 items you purchase. Here. On imaging, 0.7% difference across the board. So, you know, for me, when I was an HTM leader and I was actually ordering parts and things like that, 0.3, that's nothing. That's really not that impactful overall. So, but you have to measure that based off of also the savings. So looking at the savings, these are those 22 modalities. And if you look, just starting at the left-hand side with patient monitoring. So patient monitoring, there's a 57% savings on average over OEM pricing with a 0.3% difference in quality return rate. I would take that any day of the week. We move over to sterilization, 6% savings. So not as much of an aftermarket for sterilization parts. And the savings isn't really there. I wouldn't touch 6% savings. So I think part of the key here is you have to evaluate both the return rates as well as the cost savings, and then make a decision based on your risk profile for your hospital. What is your facility comfortable with when it comes to risk? Are they comfortable with a higher risk? Maybe going back, I'll go back one slide and look at the refurbished rate. So refurbished is a little bit higher, but there can be substantial savings when going with refurbished or tested or something along those lines as well. So just taking all those factors into play and say, hey, this thing's going out of service in 6 months. We just need to keep it ticking for a little bit while longer. Maybe it makes sense to go with an extra 1.5% quality return rate over the OEM because you're going to have some substantial savings. But really looking at all three of those factors and pulling them all together is going to give you the ability to make the best decision. All right. So this is also based on the survey. So looking at the importance of the vendor attributes and then those attributes, you can see that reliability is number one. Pricing is up there. They're very, very close. But with all these different categories, you know, you can look at these combined with all the other data sets that you're pulling together and say, okay, you know, is pricing the most important to me today on this asset, on this modality, on this criticality? Is this CT the one that needs that platinum service contract? Or can we go time and materials on it? Is this, you know, do we need a service contract on infusion pumps or anesthesia machines? Can we get training, things along those lines? But these are the priorities for imaging equipment, replacement parts. I think I see it every day. Reliability, on-time delivery. They want it good, and they want it there now. I think it's called the iron triangle. You can have it good, you can have it fast, you can have it cheap, but you can only pick two. So I don't want to say cheap, we're not looking for cheap, but we're looking for less expensive. But I think it's a funny, looking at that and then trying to apply it to your life, thinking about things in your life. If you want something now, you're going to pay overnight shipping. You're going to pay, maybe an extra cost on top of that for expedited processing. So there's all kinds of things if you want it now. So then wrapping up this section, just talking about some insights and action that you can take back today and look at. So looking at the overall budget impact at the site and modality level, I think that's an important piece. When the quality return rate is lower for an OEM than compatible, consider a threshold. Set a threshold. That's about standardizing a process so you don't have to evaluate it every time. You have a standard operating procedure that says this is the threshold. We recommend 1% as that threshold. If there's a difference of 1% in the quality return rate, maybe go with the lower of those options. Factor in part criticality or the need for redundancy in those considerations. So again, do you need that patient monitoring touchscreen overnighted? You have other patient monitors you can use, probably. Do you want to ship all your biomed parts overnight and the extra cost for expedited shipping, the extra cost expedited processing? So part criticality is very important. Can you forward stock to avoid the criticality? So if you have a system that you have some remote monitoring maybe that's tracking and you're seeing some extra things going on, can you forward stock a tube so that when that system goes down, you're down for a couple hours, not for a couple of days? I guess I jumped over into imaging equipment. So end of life, location, I talked about that, at the clinic versus in the ER. Those are different things you want to take into account. Access to redundant equipment. You have more than one of that machine. You have 2 CT machines. You have several. I mean, I've been at hospitals that have 5, 6 CT machines. Is every CT critical? And looking at it, if everything's critical, then nothing's critical. So if you apply the same criticality to all assets, you're just going to be in the same boat. So you got to look at that, and I think you got to look at it on a regular basis, on a routine basis. Equipment's coming in the hospital all the time. I know as biomed, you find out often when it shows up on the dock, and you say, hey, we're doing an install today, we need your help. But looking at that from that perspective is very important. And then, selecting a new, non-new high-dollar OEM imaging parts if the pricing differential exceeds a specific threshold. So with imaging, we recommend 15%. If that pricing differential is more than 15%, it may be worth going for that. Less than 15, it's an evaluation. All right. I'm going to pause for a second. Any questions, comments, anything anybody wants to add regarding that section? Go for it. So the quality return rate, the question was, how do you define the quality return rate? And so the way we define quality return rates is there is a category of returns, so DOA, warranty failure, damaged part, things along those lines. And those categories are when a return is initiated, we ask why it's being returned. And we have a set, I believe there's 6 different return reason types. And we define those reason types as quality. And then we track both the overall return rate as well as the quality return rate for each vendor. Oh, how is it calculated? So, I mean, it's calculated based on, if we have purchased, say, 10,000 parts from this vendor, 10,000 of that particular part, and then so many of those got returned, it's that number out of the total. So if we purchased 1,000 and we got 100 returned, that would be that 10% return, that quality return rate, if they were all quality reasons. But if say 10 were or 100 were returned, but 50 of them were because they didn't need it, they didn't like it, they bought another one or something like that, then it would be half of that return. So the data set we're using is all parts purchases through PartsSource for the last 12 months. Every parts purchase made through PartsSource over the last 12 months. So every single purchase that's gone through us over the last 12 months was contributed to the data set that we use to come up with the data that's being shared today. Non-OEM, OEM, everything. So we have relationships with both non-OEM and OEM alike, and we do purchase quite a bit of OEM parts, and so that's all factored into the data set. Yeah. And we're talking hundreds of thousands of parts. So it's a very large data set. All right, so now we're going to jump into eliminating complexity and cost in equipment service. Am I doing on time? I'm good? Yeah, I got about 15 seconds. Perfect. So I think one of the big things here is if you're not involved in equipment service and service contracts, you need to, because there's a very important piece that Biomet plays in that arena. So providers can use benchmark data to identify and reduce variations in contracts and simultaneously reduce costs and improve service and quality. A lack of standardization can really serve as a drag against that effort. Complexity, variance, and lack of transparency can also hamper access, can raise costs, and it can negatively impact quality. And then given the fact that medical equipment service contracts, I don't know if y'all know this, 50% of the typical HTM department budget is on service contracts. Some I've seen higher. So it's a big piece that we can make a huge impact on. If half your budget is going to this, what can you do to spend that money elsewhere, reduce costs, increase the training and capabilities of your team, and then go back to showing the value of your team to your facility? So again, there is a move towards standardization of service contracts by modality, terms and conditions, things like that. I've seen facilities, a lot of facilities go to a standardized terms and conditions so that those contracts can get through legal a bit faster. What I think they're lacking sometimes is they're lacking looking at the content of those contracts. So they standardize one piece of it, but they're not standardizing everything. In another couple of slides, there's a graph I'm going to show you that shows how much variation there really is across the country in service contracts, both cost and what you're getting for that cost. So what we really can do here is, using that data to identify and reduce cost variances. So if you don't have access to all your contracts, and once you get that, looking at it by model, by modality, and say, hey, you know what? Why is this department paying $10,000 a year more than that department? What are those entitlements? Do they make sense? When I was working up in Columbus at Nationwide Children's Hospital, we found that a clinic that was closed on the weekends, it was open Monday through Friday, 8 to 5, had a platinum level service contract on some of their equipment, which was 24-hour response time, nights and weekends and all this stuff, but they would never need that. They just liked that platinum agreement. They thought it was the best service. We were able to downgrade them to a gold agreement because we still needed that outside service, but we saved a substantial amount of money by evaluating that based on location and criticality. All right, so we did an analysis, and to show you where the data comes from, we evaluated over 100,000 individual service contracts and more than 500,000 service events. And that's what went into some of the data I'm going to share on the next couple of slides. So again, a very large data set, something that a hospital or health system might not have access to this amount of data, but evaluating your data is what's key. So what we found, average 146 service contracts per hospital. You see, there's not a lot of variation between those under 1,000 beds and over 1,000 beds, 16, not a huge variation. So it ranged from a low of 62 per hospital, a high of 258. I think that the low of 62, you never know how well they're doing with that. You're not looking at the quality outcomes based on that. And 238 seems really high, but again, without looking at too much of the detail, it's hard to say whether those are good. But the vast majority of these, low value contracts covering low value assets, low risk assets. So again, looking at the criticality of that asset, looking at what would it cost to bring those type of things in-house? Does it make sense to have contracts on low risk, low dollar items? Equipment contracts. So so biomed and imaging. So equipment contracts only. So this shows that regardless of price band, they're spending up to 4 months per contract. So that means for $1.5, $2 million contract on your big iron, they're spending the exact same amount of time on something for maybe infusion pumps or a low dollar item. So there's some gains to be made in processing. If you're standardizing processes, you're putting some SOPs in place, standardizing terms and conditions that can decrease your legal time. It can decrease your contract negotiation time. You want to enter a contract, you give them your terms and conditions. These are our facility terms and conditions. Embed them into your contract, and we can move forward. There's ways that you can reduce a lot of this time. But you see, they actually spend the majority of time on low dollar contracts. 111 contracts, under $50,000. 11,189 days. A ton of time to be spending on something that's fairly inexpensive in this world, 50 grand. So Taking it a step further, we also found that there were over 519 unique contracts for the exact same model across this data set. Now, there's some reason to have unique contracts, as we talked about with clinics and things like that, having a contract that works for the ED versus having one on a clinic or an offsite location, something like that. There's some reasons for that. But we also found full service contracts on OEC 9900s, 57%, okay? 18,006 at the max, 7920 at the bottom, controlling for entitlements. So for the exact same set of entitlements, the exact same hours of operation, the exact same PM requirements, some facilities are paying $7,900, some are paying $18,600. So if you don't have a global view of your service contracts, how would you even know if there's this variance across your own health system? A lot of savings there, a lot of savings potential. If you find out that one clinic's paying one thing, you're paying one thing over here, and it's the same health system, you can go back to that vendor and talk to them about that. And when it comes time for renewal, you can renegotiate the heck out of that contract. So something you really want to look at is not just the pricing, but the entitlements within those contracts. You need to find a way to be able to look at that as well. This one shows even more variation. So you can see these are the different service contract types. We looked at in-house, parts only, parts and maintenance, time and materials, everything. And you can see, like, if you just look at X-ray, top line there. There's in-house, there's parts only, there's T&M, there's first look, there's full service OEM. So there's such a wide variety. I mean, you can see with lab analyzers, go to the far right, the biggest blue dot on the screen, most people contract those out, full service. But there is quite a bit of variation. So it suggests that there's a lack of an evidence-based approach to those assets with such a wide variation based on those modalities. Whoops. There we go. All right. So then again, looking at just from a modality perspective, you can see these are just some examples. We kind of took the actual models out of here, but you can see on the top one there, full service contract is $3,800. Average T&M spend is only $1,500. 60% savings roughly. That's something that I would cancel that contract in a heartbeat. $1,500 versus $3,800 any day. You go to the bottom, 16%. I know we talked about earlier a 15% threshold. 16 is right on the edge there. You got to make that determination. But for me, I would probably go with the full service contract. We're only talking about a $900 difference, and I can cap my costs and walk away for something like that. But having the information to look at this and then make those decisions, that's the important part. Coverage year. So we took all the contracts, and if this one was 1 year, this one was 3 years, this one was 5 years, compiled all those together. So the total contract years for that model, 463 contract years combined across the entire database. Yeah. Right. Exactly. Yeah, it's like you teed it up perfectly for the criticality conversation. So it's not just saying this, you go, yep, 60% savings, go. What is that asset? What is that model? How important is that clinic? Is that the only one they have? How much revenue does that bring into the facility? What is the impact if that goes away? If you have multiples again, then that's something you can make a decision. I'll talk about anesthesia machines, for instance. Having a spare anesthesia machine in the OR is just one of the most important things. I've been in facilities where they don't, and they end up, if an anesthesia machine is down, they shut down an OR. Like, that is one of the cash cows of a hospital, is the operating room. And so spending the extra money on that, or having that type of contract that person will be there that day or that afternoon, those are those other factors you want to bring in. Looking at cost alone isn't going to get you there. But thanks for bringing that up. That's a great point. Well, just if it's under 15%, it's probably not a good bet to go with. So, and again, thresholds are subjective. It's what is your risk profile for your hospital? How willing is your hospital to take additional risk for those cost savings? If they say, I want to save 10% off your budget next year, and you say, we can do that. We can cancel this, this, and this. Here is the impact from that. We could save this much money maybe, but how fast will they be here? Am I now a preferred customer because I just canceled my contract? I know that's a tactic a lot of people use, and it's true. You're not the top of the list if you're not a contract customer. So factoring that into it, but looking at that 15% savings is kind of that below 15%, probably not. Exactly. And a lot of that depends on what pressure they're under. Some facilities have more money than others. We all know the different spaces. I mean, children's hospitals tend to get a lot more donations, so they spend a lot more on equipment. They have wings named after every person in the city that has money. So that's a benefit for them sometimes. Smaller facilities are going to have to crunch these numbers a lot more. Those dollars don't go as far. So yeah, factoring in the criticality is definitely a big piece of this. All right, and then again, with insights and action, so these are some things that you can look at today. You can take this back today and start looking at these. Consolidate and rationalize contracts with evidence-based insight. So getting the global view of your contracts, calculating all those factors, that turnaround time, how fast are they going to be there, is that piece, the critical piece. Create a data-driven transition plan for those low dollar, low risk. Look at them and say, hey, if we brought this in-house, we would save this much money right off the bat. We would have to spend this on training or whatever it may be, but create a plan that can be backed up with data that the C-suite can take in, look at that and say, yeah, that makes sense. Let's do that transition. Use evidence-based outcome data to lower contract costs by as much as 60%. It's like we were saying on the 57% or 60% on some of those savings. Look at that, and you can lower your contract costs quite a bit. Asset level service costs and performance. Again, talking about that specific asset, not just the model. Is that asset critical? Do you need somebody there today? And then lastly, leveraging national benchmark data. So there's a lot of data sources out there that you can get. There's probably some samples you can get for free. There's data you can purchase out there looking at benchmarks. So I know ECRI does some different things with benchmarking. So leveraging that national benchmark data, but also looking at local data as well, labor rates, things like that. Go ahead. Yep.
Min and max, and you can do that at one of the data points, getting the lowest price.
Yeah.
It's
a great example. What he was sharing is that ECRI has a service that they give you the min and max for a specific piece of equipment, and then you can use that as a negotiating tactic to work with that vendor or the supplier to negotiate your price down. ECRI, ECRI has a service for that. I believe it's a paid service.
It is a paid service.
Yeah, I haven't used it myself in a long time, but yeah, it's a paid service. And right, yeah, verbally, not in email or text messages. Perfect, yeah, so they do it with contracts as well, so you can do that. That's great. I mean, so there are services out there. Again, PartsSource did this with our customers, and we've evaluated this so that obviously we want to try to do what we can to help our customers, but also there's services out there where you can go do it yourself as an in-house broker. So just look at some key takeaways from the two opportunities we discussed. Look at the overall budget impact at the site and modality level, and then consider a quality return rate and pricing differential threshold. So again, it's up to you. It's up to your risk profile how you decide on that. But putting those thresholds in place and kind of cementing them into an SOP or a procedure or policy will help reduce some of the time spent on evaluating these in the future. So if you spend the time up front now, set those thresholds, put those SOPs in place. When those things come up to evaluate again, you go, well, we already have all these things that we decided on. Now we just need to worry about some of the other details. And then on eliminating complexity and cost and equipment service, consolidate and rationalize contracts with evidence-based insights. I mean, I think that's the bare minimum. It's pulling everything together, whether you're responsible for it or not. Maybe there's another department in the hospital that handles all service contracts. Working with them to parse out the medical equipment contract and being part of that discussion and looking at just the medical equipment contracts holistically is going to give you a lot of gains. Then create a data-driven transition plan, as I just mentioned, to bring those low-dollar, low-risk ones in-house. We all want to save money, and I haven't met a single technician that doesn't want training on a piece of equipment. They're always begging for training. If we can save money, spend a little bit, get them trained up, it's going to reduce your response time so people can be there right away to respond to those, and you're saving costs. I mean, that's a win-win all around. So the conclusion is, you need to embrace the future for improved outcomes. I think data is that future, and it's very key. And I just pretty much said that. So I did have one more chart I wanted to share with you all. And this is kind of a past state, future state. Now, I'm not going to sit here and read through all of these, but just focusing on a couple of them that I haven't really talked about. Like looking at buying majority OEM parts. I think that was something, that was a reality back when I started in biomed, is that OEM was considered king. The OEM's the best, right? It's always the best. We weren't looking at all of the other factors and saying, well, we can save 57% on our patient monitoring parts if we accept a 0.3% quality return rate increase. That's something we weren't looking at. But so now going back to, buying high quality compatible refurbished parts, having those vendor partners that provide those. I know there are several of them here today that we work with at PartsSource that are great, high quality aftermarket vendors. Lack of standardized nomenclature. Again, I was talking about that hospital. I had to clean up a lot of their CMMS because they lacked that standardization. I think a big piece that I ran into when I first got into management was non-reproducible tribal knowledge. When I got into management, it was because my manager left one day and never came back. And I started attending meetings, and then a few weeks later, my boss at the hospital said, hey, can you take over? I had none of his knowledge. I had no institutional knowledge of what he had done before. So I had to pick up the pieces and try and figure it out myself. By going with a data-driven approach, it's repeatable. It's transferable. It's easy to give somebody else the data set that you already evaluated and then move from there.
That's a versus a battery.
Yeah.
Decide what is OEM and what is that.
Yeah, Salim was just sharing, you should do a risk analysis. OEM, so there's certain situations, life support is a very common one, where with life support equipment, you don't want to go aftermarket. But is it everything that you don't want to go aftermarket? Can you buy the trim knob for an anesthesia machine aftermarket? Is that a critical component of the machine? I bet you can buy that aftermarket. It's not going to impact quality. But for batteries or something like that, I think that there's a feeling that aftermarket is not as equal as OEM. In fact, aftermarket has been showing that they are stepping up the game, and in many cases, especially with batteries, they're performing better than some OEMs.
The batteries may be made at the same factory for OEM and aftermarket. However, the way the quality assurance, the internal capacity of a battery is going to be higher percentage for OEM than for OEM. So the quality likely is
Yeah. Right, but is that a data-driven decision? It's not. It's not, because I can remember aftermarket batteries failing as well, and people losing their mind. But I also remember OEM batteries failing, and everybody's like, it happens sometimes. Wait a second. Right.
So if there was a patient harm, then the risk was the OEM, the designer, and they own the risk because they cleared it from obvious. But the aftermarket, you can't go after them for their quality department. That makes sense. So I can go back to the OEM and say, this is not acceptable, and then that could push a recall. The aftermarket is not.
I agree with the class 1 recall. I tend to disagree with quality, but I think that's an opinion-based situation, and we have the data to show that the quality is not that different. It's pretty close. So again, that goes back to your tolerance for risk at your facility. Are you willing to do that? What's the cost difference? Let's say the OEM battery is $200, the aftermarket's $150. For $50, let's just go with the OEM because that's what people are comfortable with. You do have to factor in that preference. But looking at it from a data perspective, if you track things where how many OEM batteries failed over a period of time, you could probably see that the failure rate is going to be fairly similar. I think the capacity piece that you brought up, you can test it, but I think a lot of aftermarket battery providers are getting a lot better. I know we focused on batteries, but I'm just saying, again, you got to factor in all these pieces. So if it's life support gets OEM, that's a decision, but that decision should be backed up with data. It should say, well, the cost is going to be this much more, the quality rate is this, and because of these past situations, patient harm, wherever it might be, we're going to stick with OEM. We're accepting the extra cost.
We have battery shortage to all that.
Right.
Like, should they have no battery?
Again, that's the decision you have to make is do you have good experiences, or are you willing to try that and going back to that risk? So, and that kind of finalizes out the list. Zero risk tolerance. That was a hospital I worked at. There was zero risk tolerance. They said, no matter what the cost, buy the OEM, buy that because we feel that it's riskier to buy aftermarket. But I think looking at criticality again, where does it make sense? You know, like a roll-around patient monitor that you're just doing blood pressure checks, that can get an aftermarket battery. If that fails, you're not delaying patient care that much. You know, the clinician can always take manual blood pressure. So factoring that model-based piece is key. All right, so the end, data's here. Got the data. The evidence is there. The technology is there to do it. There's a lot of different ways that technology can support you. So it's time to leave the status quo behind, embrace the data-driven model. All right. Thank you all today. I really appreciate the participation and the comments. We're at booth 49. So again, this was not a sales pitch, but if you are interested in anything PartsSource, you have any questions, myself, Nicole, Chelsea, Stephen that joined us, we'll all be at the booth later on this afternoon. So stop by and see us. And again, I just appreciate you guys coming out. Thank you. And Celine, for you, I wanted to share, well, everybody's welcome to this. I want to share, I took a couple of snapshots of some of our supply scorecards. So these are some of the factors that we track. These are just a couple of snapshots. I know all the pretty graphics, but we're tracking it by SKU, return reason, POs, dates, all of that stuff to look at our quality return rates over time. So we set thresholds for our vendors as well. It's if their quality return rate has exceeded a certain value, we will issue a SCAR. We will work with that vendor to help them improve. If they fail to improve, we have no problem turning that vendor off. We don't have a preference based on name or relationship. We have a preference based on price and quality and balancing those two factors. And then here's another scorecard that I took a snapshot of. So it just shows returns, tracking, quality, quotes. So we're not just looking at quality returns. We're looking at, are they providing us quotes in a timely fashion? Is that an automated piece? Do they have the best price? We're not just looking at price, quality, returns, providing tracking, because I know when you order a part, you want to know when is it going to be here? Once it's left the facility, you know, it's a little bit of a black hole if you don't have a tracking number. So we rank our vendors based on all of these factors, pulling in all that data and making that decision based on that. All right, thanks, Ian. Yeah, I mean, it's a great dashboard, and it's a lot of good information, and just trying to make it not salesy, but also talking about how, and it's important to track a lot of these factors and you can make better decisions if you have them.